see
Yes,
your
we
slides?
can
Go
see
right
them.
ahead, please.
Okay.
And then we'll
Okay,
bring you
here
into
we
our
are. So I
round
just
table.
need to give you an overview what artificial intelligence is, and it's a large umbrella with multiple terms that we have used, and there are subcategories. And you will hear various terms during various talks, especially if it's given by a computer scientist or something. So what we'll see is various kinds of subcategory of AI has been used here in Mount Sinai, and we have done so many of our projects using them. The biggest and the newest that is coming up right now is the agentic AI, and we will talk about that more. So now, what are we doing using is, one is yellow studies and the AI genomics. So yellow one, we use yellow for the last 15 years. We are working on the various studies. And the first one was a yellow one where we used in obstructive coronary lesion with less FFR. We used standard of care with rosuvastatin, showed at 6 to 8 weeks there was a decrease in LCBI. Then in yellow 2, we used imaging, which was both NIRS and the OCT. Again, in obstructive lesion, lipid-rich plaque, what we used this time is to understand cholesterol efflux in patients to see how exactly there is a change in the morphology of these patients. So we definitely showed that by using just rosuvastatin single arm, that in 12 weeks, there was a change in fibrous cap thickness, which correlated with improvement of cholesterol efflux, the way we think the lipid comes out from the plaque. And we used what is called as understanding gene expression, why this happens in patients whose plaque morphology changes, 6 key genes that was associated with cholesterol metabolism and smooth muscle cell we came across. So this one in 2019, we used what is called as machine learning. The entire gene panel was entered into a machine learning model, and we predicted fibrous cap thickness change to statin therapy based on their baseline genes. LO3, very complex study. Again, patient had to have a lipid-rich plaque. They had statin therapy. Once we knew they had lipid-rich plaque, all of them got avelumab for every 2 weeks for an addition of 26 weeks. When they came back, we repeated the imaging study. So what was important, we did a different kind of genetic transcriptomic analysis, which was a bulk RNA sequencing. If you see here, close to 329 patients screened and 110 patients completed. Very complex trial. So significant decrease in total cholesterol and LDL when they came back. And we know that avelumab does not change CRP. So improvement in fibrous cap thickness when they came back, significant improvement. And a change in LCBI when they came back, which means a decrease in LCBI, which we call this melting butter sign. That is what we see. We then grouped the patient who responded and who did not respond. 80% of the patient responded, what we call increase in fibrous cap thickness, and about 76% of the patient, there was a decrease in LCBI. Look at their LDL level. There in the left corner here, significant decrease in the LDL also. Then there was a group of patients where we saw, despite change in their LDL. So if you take their chemical markers, LDL baseline 78, when they came back, LDL of 7. But no change in fibrous cap, no change in LCBI. We call them as non-responders. Why does this happen? So if we are treating patient just looking at the LDL, is there something we can find with this patient? So always the question is, was a response in total cholesterol and LDL for the treatment was different? No, both of them decreased their LDL, total cholesterol and LDL to the same extent. So this is a heat map which showed there was a significant upregulation of some genes and downregulation of some other genes. Now we see the genes. So if there are genes, what does it we come up with? Means these genes are associated with certain pathways. So what we saw is patients who responded had upregulation of what is called as a mitochondrial translation, crystal formation, protein synthesis, very important for plaque stabilization. And there was downregulation of what is called as mitochondrial dysfunction. Then what we also found is responders, non-responders. We went deep and found out that in responders, again, mitochondrial function improved, non-responders, mitochondrial function did not improve. there was increase in neutrophil degranulation and inflammatory pathway. This is the key, that we used machine learning. The entire gene panel of 38 baseline gene, if you see here, was entered in the machine learning model, and we saw the important gene that we could predict that these people, if they have these baseline genes, they are likely to respond. Their fibrous cap thickness is likely to respond to treatment, which is one of the key findings. The same thing we also found for LCBI reduction, again a machine learning model with 71 baseline gene. So essentially, what is it? Mitochondrial function improved in responders, and because of various other genetic changes, there was plaque stabilization. So machine learning model can now predict fibrous cap thickness and LCBI response based on their baseline gene. And that is what we are going to focus on yellow for, so we can get to a personalized approach for treating patients with CAD. So going to how can we use AI in analyzing angiograms and doing reporting. Half our time goes in reading angiograms and doing this. So like I showed you, right, there is various subcategories of AI. Many of the models you do what is called as you give training. Some of the models you don't train. So what we did was we did annotation. We trained this. This was a part of machine learning where we did 800 angiograms, did that training, and now we can get an automatic report as soon as angiogram is done. We have the software up here. So the question comes is, was your model validated? Yes, we validated our model with the gold standard QCA with excellent intra-class intercorrelation. So it is the key. One who trains, it has to be the expert in the field, has trained the model, and the model has been validated. Now, what we are doing is, with the same QCA, we are going to bifurcation lesion, understanding bifurcation lesion. We are feeding, how do you treat this particular bifurcation lesion, the step-by-step PCI guide that we are doing. So the next one is, we have multiple, databases. One of them that we did, which we presented actually in EuroPCR, created a model that can be, by using various CT scan, that can we get valve sizing, and we were able to do that with a model that we have created. And this is the future, which is called the learning that we are going to be doing, which will be using an AI agent, but more important is the observe the environment and these changes. Now, let me tell you, what is it that we are going to do by using what's called as reinforcement learning. This is coming up, and this will be the future of what we have to do. So multiple places we can be doing reinforcement, which is clinical operation, procedural support. More important is real-time understanding what kind of equipment you need. Right now, I was telling them, give me this, give me that. That is because how my brain is functioning. Question is, can we train the model to say which device you need to use? And hemodynamic monitoring optimization, that can you predict that slow flow is going to happen in this particular vessel? That is what we are working on. And of course, other things, patient encounter and various things will happen. Reinforcement learning is what we are working right now to understand integrating angiogram. We have our cath report, we have ACC NCDR outcome, and we have our electronic medical record. This is an unsupervised part of AI. We are just going to give all the data and then see what we can find, or can it mimic human brain. Now coming to what is called as a patient encounter, one that we have created in Mount Sinai. So if you see here, Mount Sinai cath lab volume, almost 16,000 patients. Each patient takes about 15 minutes for the phone call. We created what is called as Sophia, who will be the virtual USA pageant with a beautiful Indian face and a Spanish name, Sophia. So listen to her voice.
I am Sophia, a virtual assistant specifically designed to assist patients like you with their cardiac care at Mount Sinai Hospital. My focus is on providing clear, accurate, and helpful information about your procedure, answering your questions, and ensuring you're well prepared.
So How was Sophia created? When you call agentic AI, multiple agents are created. Each agent knows what topic they need to do, and there are guardrails, which means that Sophia was only made to talk on cath lab procedures. And if somebody asks some other questions not related to the cath lab, she's not going to answer. There's escalation pathway. She'll politely say, a clinical team will call you back. And this is the simple way that you have created. As soon as we have our procedure, Sophia is going to call them. They're going to give logistical questions. There's a portal to understand what is happening with each calls. Then we have already created the regime where if for logistical reason or for clinical reason, the nurse will call back, and this is predefined. Once it is done, nurse will verify, and then that will go into the EMR. This is what the conversation view looks like. Very important. The nurse can quickly go through the conversation. There is an AI call summary. This particular patient was taking blood thinner and wanted to talk to a nurse practitioner, which means a nurse practitioner should call back. And then it is already clarified that the patient said he's taking warfarin. And then what happens is the nurse will do a verification and it will go. So we already tested 90 days, 4,000 minutes of Sophia was done. And which I say that if I had not listened to her for every single minute, could have watched almost 27 Bollywood movies. But what we did was myself and my team reviewed every single call, 806 calls of Sophia, about 588 patient surveys we got. This survey again was IRB approved. Our oldest patient that dealt was 91-year-old. So this is what we found. The biggest thing is adoption of AI by the physicians, adoption of AI by the patients. And what we came to see that yes, everybody is adopting AI. Call completion 86.4%, non-completion 13.6%. The biggest problem everybody thinks is what is the AI system reliability? Biggest problem is hallucination. Like I mentioned, if they don't know the answer, the agent starts making up stories. Absolutely. Hallucination of 806 cases or 6 patients only, which goes to say that if you train the model and you have important guardrails, there will be no hallucination in this agent. So it has to be done well. So then these are our, what I would say is the questionnaire, IRB approved. If you see here is a customer satisfaction score, 8 to 10. Most of the places we got 10. This is the overall score we got from the patient, 94.88%. One of the important testimonial from the patient, extensive experience testing technologies like Mount Sinai Virtual Agent, Sophia. My interaction with Sophia was seamless. She was clear, concise, gave answers in written. Every hospital should have a system like this. What we are trying to say is this is the future. So in every way, she did very well, whether we go to performance, trustworthiness, efficiency, or empathy. So there are a couple of other things that we can talk more on. But now we go to outcomes. As an interventional cardiologist, what people want to do and continue to do is save lives. So what we worked on is creating the app for STEMI, which I showed it in the past. And we know there is only limited improvement that can happen. This is way back from 2010 to 2016. Door in, door out, which should be 45 minutes. But if you see what happens, even to this date, is 58 minutes. This is JAMA Cardiology 2022 publication from American Heart Association in America. Right now, if you see here, the only 25% of the cases of the transfers are meeting less than 120 minutes goal. So there something has to be done. What can we do? Because this is the only place where we know we can save time. So we have been working on this since 2018. The app has been working in various parts of Mount Sinai. Now in 2025, we are going to be using AI. So this is what we want to show. US average time was less than 120 minutes, was about 20 minutes, 20%. We were about 70%, but after using the app, less than 120 minutes. Okay, you did your case in less than 120 minutes. So what? Look at it. Look at our in-hospital STEMI death and compare it to the ACC NCDR. Our death is about 0.3%, whereas for USA is about 2%. So what are we going to do using AI in our version 2 is AI detection by EKG, EMR will provide, summary details by this agent. All the various stakeholders will be called by the AI agent, Sophia. And more important is it will automatically give you quality metrics. And other thing is you can use this for other disease pathway. So what we think how patient coordination is going to happen, Sophia is the one that is going to be making calls. So the ER physician talking to me, and this is the transfer center, ready to send the ambulance. So no, that was a movie, but somehow it's not playing. So what is the future directions that using AI here in Mount Sinai? You guys do not? Movie is not playing. Anyway, machine learning to use definitive panel of biomarkers using proteomics, transcriptomics, metabolomics, so that we can do a personalized lipid lowering therapy. Like I showed you, PCI guidance, especially for bifurcation, then we will move on to calcification. That is based on deep learning and computer vision. Then goes AI-rich database, which is a reinforcement learning, which is a key. This is the future, and that's what we want to do. And Sophia, we know we are going to expand it to other use cases. So what does Sophia use? Natural language processing, deep learning, LLMs, and all of the above. Of course, our STEMI app will be the next one. So all of this has come from what we call is a Kini think tank. The left side, you can see that is the think tank that's happening. And these are my people who are helping me to bring this think tank to the future. Any question, you can email me. That is the AI, Nano Intelligence. Yeah, thank you.
All right,
I know I went over.
Thank you. I want one short comment from Dr. Antoniadis. You just heard about this AI tools in our cath lab. You saw that there's imaging involved. What is that? What happens? Many of us are score of 0, cholesterol high. What are we supposed to use your technique, or what are we supposed to do?
That's a very
short answer.
That's a very good question. Calcium score 0 is a good indication that you are very unlikely to have an event imminently. However, there is a 5% event rate over the decade. Getting your calcium score 0 doesn't give you a warranty. You have to measure also inflammation, because this happens before plaque is formed, and that's essentially what you need to identify, the inflamed arteries. CRP is it's a plasma biomarker, and it doesn't tell you where there's inflammation in the coronary artery. So you have to use a CT to get this information before plaque is formed, so that you can prevent plaque formation, not only plaque rupture.
Fantastic. So thank you so much. Dr. Kini, I'm sorry, any final words, because we need to move on. We're literally 30 minutes behind.
Yeah, the new terms, everybody's talking AI, but the prediction I'm telling you is it is not easy to copy the human brain.
Oh, love that. Yes, thank God. Okay, thank you very much.